So learning from our mistakes is the best way to learn. And I thank AIOC and really thankful to everybody out here who has spared time, traveled all the way, and are here to share the views and to learn. So learning has to be bilateral. All are free to give their inputs. Nobody is a dedicated speaker. And here we prove that we have made mistakes, and we'll show you what mistakes we have made. I welcome all my speakers, all the audience, and a special guest, Khatri sir. He is here. We'll grace the occasion and we'll welcome his expert remarks that will guide us further to be better clinicians and better surgeons. Phaco emulsification is the commonest surgery which we perform in our day-to-day practice, and we do all the cases with the best of diligence and the most pious intentions. Neither the package matters nor religion, sex, nothing matters. The eye matters. We just remember that brown cataract patient, that small-eyed patient. We never know what the name was even. So on the table, I don't think anything else is seen except that dilated pupil when we are operating. So the intentions were very good always. But sometimes you land up with one patient who is very unhappy. So what went wrong? We never wanted anything wrong, but it is bound to happen. Sometimes not in our hands, sometimes luck, sometimes patient's luck, sometimes technology ditches, and sometimes really some error happens which we could never foresee. So those are small entities which we are going to discuss here today. We have a beautifully crafted panel. With me is the legend, Dr. A.K. Grover sir, Dr. Suhas sir, the pioneer in phaco emulsification. We have Anaga ma'am from Mumbai, Professor Shalini from GSVM Medical College, Kanpur, Dr. Manish sir from Khairabad Hospital, Kanpur, me myself, and so we shall be giving our best possible inputs to tell what error we did and what best could be done to avoid those errors. So I invite Suhas sir to please come up on stage and take seat. Shalini ma'am, please come up on the stage and take your seat. Anaga ma'am, please come up on the stage and take your seat. Manish sir, please come up on stage, take your seat. Some overlapping sessions as expected in any conference. Because of that, we have shuffled the sequence of speakers. First talk in our session would be taken by Dr. Anaga Herur. She is a dynamic personality in our fraternity, and all of us in India know her very well. She has been traveling and traveling. She is at present the secretary of Maharashtra Ophthalmic Society, and it would be evening if I enumerate the awards which she has received. So no further detail. She is medical director of Anil Eye Hospital, Mumbai, and a surgeon par excellence and a very good orator. So we are lucky to have her here, and ma'am has spared some time to give her presentation. I invite her on the stage. Please come, ma'am. She'll be telling us what errors do creep in biometry so as to have an unhappy patient.
Thank you so much, Dr. Mohit, for your kind introduction, and thank you for including me in your IC. He has given a beautiful introduction as to what exactly this IC encompasses, and my job here is to discuss how at the first point in your contact with the patient when you treat cataract is the biometry, and at which places can you actually go wrong and what you can do to avoid those mistakes. So let's see what the sources of error are. First of all, how you actually capture data, whether it is measurement of keratometry or axial length, what formula you're going to use, whether there are any manual errors. I think in a busy practice, this becomes extremely important and it is not discussed. And this you need to continuously speak to your technicians, optometrists, whether it's a mislabeled IOL, transposition errors. And yes, in various extremes of situations, there is a very high risk that you can go wrong and you need to be doubly careful and very alert. So first and foremost is when you do a keratometry, what are the tips for getting an accurate manual keratometry? The most important thing is the cornea should be pristine. You should not have put in anesthetic eye drop or done an applanation or gonioscopy. It has to be a pristine eye with a good ocular surface. That will give you clear-cut, perfect keratometric readings. If you have a reading which is less than 40, more than 48, get it rechecked. If there is a discrepancy in multiple readings, then call the patient again on another day, pre-treat the ocular surface, and then you will be amazed to see how the readings would be totally different and you can go totally off track. Always correlate with topography, especially if you are contemplating patients with premium IOLs like torics and multifocals. So if you look at which of these will give you what kind of error, in keratometry, a 1 diopteric error will give you a 0.9 diopter error in the IOL power, and in axial length, 1 millimeter will give you an error of almost 2.5 diopters error in the IOL power. And yes, IOL formula errors are galore. So for example, let's see a few cases. Now this was a patient where you can see there's a little flattening on the inner side, on the nasal side, and this was a patient with pterygium. Look at the higher order aberrations on corneal wavefront. The horizontal coma, horizontal trefoil is high. So if you're not very careful by doing the topography, correlating the astigmatism with the patient's IOL power, he's not going to be happy at the end of the day, and you will end up having not only an unhappy patient, but you would need to deal with these situations post-op. So if there is a pterygium like this, it would be prudent to first go ahead, do the pterygium surgery, allow the keratometric measurements to stabilize, wait for 2 to 4 weeks at least, and then go back and do, and probably all these figures would have changed by then. This is another patient where a topography easily shows how there are dry spots on the eye. Anytime you have multiple readings showing changes in the astigmatic power amount, or if you have dry spots like this, put the patients on lubricants, recheck the IOL power, and it will be probably different. When you're doing an immersion biometry, it is very, very important to look at these graphs. How will you know whether your check has been right or not? In fact, the optometrist or the technician, whoever is doing it, has to look at these graphs, and ideally you should look at printouts of this. So you should have these 5 peaks. You should have that perfect 90-degree rise in the peaks. You should have the separate retinal scleral peaks. And then you would be knowing that yes, your immersion biometry has been perfect. What are the potential sources of error? I think it is time that we have a complete stop to contact biometry, because that gives a very high risk of error. For example, you look at the short eye, it gives almost a 3.75 diopteric error for every 1 millimeter of corneal compression. So I think we should no longer use the contact method. We should completely switch on to the applanation, to the immersion method. So what are the other common errors? So if the beam is not perpendicular, you have many times a red spot where the patient can actually see. If he is not, and if it's not directly perpendicular, then again you will have a retinal spike that is not perfectly straight, and you will end up having an error in the axial length measurement. This is another example of that the sound beam is directed at an angle through the lens and it's not going perfectly central. Now let's look at what IOL formula we use for different axial lens. Today, yes, Barrett Universal 2 is the gold standard that we can use for all the IOL axial lens. These are some of the literature that have shown the IOL power calculation in short eyes as well as long eyes. But today with the Barrett Universal 2, I think we have a great dependable IOL formula which we can use for all these conditions. Now let's look at a few conditions which are more at risk of giving us errors. High myopic eye, for example. In these high myopic eyes, what do you think would be a better way of doing an immersion biometry or an optical biometry? Any guesses? It's definitely the optical biometry, because there you're actually having the visual axis. It goes on through the visual axis. If you have a posterior staphyloma like this, which causes irregular shape of the ocular wall, the visual axis may not be directly in the line of sight, and you can end up having a change in the axial length, which can cause a very significant error. So the deepest portion of the staphyloma may not be exactly located in the macula, exactly in the center, so the measurement could be different. It's best to correlate it with the ultrasound B scan in these patients. And if you're doing immersion biometry and optical biometry is not possible in these patients, then remember to keep asking the patient to fixate on the light that is there. You can also use the Bangkok axial length modification for better accuracy in these patients. Even if you're using an optical biometry, there are some instrument errors and how you're actually capturing the data that can cause errors. So for example, this is the correct position, and you can see the astigmatism is 1.48 at 105 degrees, whereas if you have a tilted position, then the astigmatism totally changes. So especially in premium IOLs, you have to be very careful as to how you are taking the data and how you are capturing all the images. Now, dry eye, for example. Now look at this example. Now this is the right eye, 3.22 diopter of astigmatism, and it changes to 2.36. The left eye, 3.67, changes to 2.9 after treating the patient with lubricants and treating the ocular surface. So be extremely careful in all those high-risk patients like diabetics, patients who have thyroid disorders, meibomian gland dysfunction, who are contact lens users. Ensure that the contact lens has been off for at least a week before you are doing it. So issue of dry eye is very, very important when you are using premium IOLs, especially multifocal IOLs. Now look at this example. Here it's a toric IOL planning, and the induced astigmatism, the SIA has been wrongly put as 3 diopters. And look at what is the IOL power that has been selected. It's a T3 with a 0.4 residual astigmatism. You change it to a correct 0.3 diopters, and it is T5 with a 0.3. So each and every part of your planning has to be perfect, otherwise you can end up having significant refractive errors. Now we talked about how optical biometry is more accurate compared to the immersion. But if you're looking at this high myopic patient, I'm sorry, I think it's not very clear on this, but the IOL formula used is wrong. The SRKT versus the Barrett 2. Here you can see a change of -0.5 and a -2 diopters. So you could have easily ended up having almost a 2 diopter of error. Similarly, in high hypermetropia, the Barrett as well as the Hoffer Q will give you a much higher accuracy rather than other IOL formulae. In keratoconus, remember, these are unique challenges. You have a decentered corneal apex, displaced visual axis, variability, poor repeatability, and less accuracy. So in these patients also you have a lot of literature. Here this IOL lens power calculation keratoconus shows an SRKT, but then the latest literature shows that the Barrett gives you a better accuracy, the Barrett True K here. And definitely today with the IOL Master, you can use the total K for all these patients. Eyes with silicone oil are again very special. We need to remember that the sound velocity in silicone oil is lesser than that in the vitreous, and this can cause pronounced sound attenuation and difficulty in identifying the retinal spikes, and that is why you can end up having a serious error in these eyes. Now look, for example, in this, here again there is no role of immersion biometry. You have to use optical biometer with the mode selected as silicone oil. Now for example, this is a patient where the optometrist has wrongly selected as vitreous body and not as silicone oil, and see, she has got an IOL power of 22.5, whereas actually it should have been 25. So there could have been easily a 3 diopter error. So this has to be taken care of. Post-keratorefractive surgery, you have to be extremely careful. The IOL formula that are recommended are the ASCRS online calculators, the Barrett True K, again with the total K will be more accurate, Haigis L and the Shamas. You have various forms that you can use for prior myopic, prior hypermetropic, and prior RK. You know why these problems occur is because you are ignoring the flatter central region, underestimation of the IOL power, and causing a hyperopic outcome. It's different in RK as well as in LASIK. In LASIK, it's basically the changed back to front ratio that is causing the error. Now let's look at a few examples and then I'll be done. Just last 1 minute. This was a 48-year-old patient, myopic LASIK done 10 years ago. Always do a topography for these patients. You can see that there is a high positive corneal spherical aberration which can cause glare and halos, and there is a decentered ablation also which you can pick up. Now let's see what can go wrong in this. So this was a ASCRS online calculator that we used, and you can see it gives you data of average, minimum and maximum. The maximum here is 12.4. What we used was 12.5. Now look at on the right where you're using the IOL master readings, but it shows LVC untreated. If you're using the wrong mode, no matter what IOL formula you use, even with the Barrett, it will give you wrongly 10.5. So you have to be very, very careful. Suppose you're using the Barrett suite, it is giving you correctly 12.5. Remember, the Barrett is included as a combination of formula in the ASCRS online calculator. So you can use either the Barrett or the ASCRS online. With the Haigis suite, again, it's giving you 12, which is same as what you would get in the ASCRS online. And again, so this was what we needed to, the message to go across. Post-operatively, this patient did extremely well. Again, RK is a different situation altogether. Very flat corneas and very small optical zones. Use the ASCRS online calculator and always target myopia. This was an 18 cut and we targeted almost 1.5. So the maximum was 26.8. We used a 28 and we got very good results. Again, remember that LVC untreated is wrong. You should use the RK mode, otherwise you will end up having a hyperopic outcome. So this was the patient. Just the last slide. Remember also, this is the same thing. You need to target myopia in post-RK patients. This was what we got on the first day post-op, plus 2.5. Now remember, in post-RK, the first few weeks, there could be a hyperopic outcome which is transient because of corneal edema along the incisions. Wait for 3 to 4 weeks and then the spherical had settled. In post-corneal transplant, DSEC, for example, causes a hyperopic shift. So use an IOL with a minus 1.25 or a minus 1.5 myopic. These are rare cases, but we need to remember and be alert in these cases. So friends, a very good preoperative assessment is very important to get more precision and accuracy in all your cases. Thank you so much for your kind attention. Thank you.
Thank you, Anaga ma'am. It was really enlightening. So amidst our instruction course, we have a guest speaker to have a keynote address, our past president, Dr. Krish Maskati sir. I invite him upon the stage to deliver his talk on quality of life in dry eye patients.
Thank you, Manoj. And I feel like a good strain engine, which has been, because it was a keynote address, and the scientific committee then just found an available hall to latch the good strain engine to. So it's not necessarily something directly connected with this session. I apologize. Just one comment on what Manoj said in the beginning about what are the things that can go wrong and make an unhappy patient. Sometimes there are patients who are unhappy because they choose to be unhappy. So it's not your fault, it's not instrument error, it's just that the patient has chosen to be unhappy. I did a black cataract patient who came to me in the pre-op. In the chatting, he was talking about whether he should adopt a child or not adopt a child, means completely extraneous issues that should have triggered a warning that this man is cuckoo. But so I did the black cataract to the best that I could and gave him 6/9 vision. And then in my 35-40 years of practice, I'd never been sued. This was the first time I got a legal notice, because he told me that when he drives at higher than normal speeds on the Mumbai-Pune expressway, which is at 120 to 140 kilometers per hour, at that time the legal limit was 80. Then he sees halos around the lights. I had put a monofocal. So he's seeing halos around the lights. I said, what happens if you drive at 80 kilometers per hour? He says, then I don't see them. So for that complaint of his, I got a legal notice. So sometimes it is the patient who is unhappy, who chooses to be unhappy, nothing that you have done. So don't always blame yourself or errors in biometry or instrumentation. Just this, so I had to say something on the topic of the day, and then to go completely off tangent now. I'm talking on quality of life issues in dry eye patients. I've been talking on dry eye since about 20-30 years. People have stopped wanting to listen to me. So I came out with something else, which is dry eye, but why we should continue to talk on dry eye nowadays, because we have something called QOL, or quality of life issues. This is not used only in ophthalmology, it is used in every part of the body. In angina, what is the patient's quality of life? In somebody who's got pneumonia, what is his quality of life? Heart attack, what is quality of life, and so on. Depression. So we look at dry eye not only from which drop to use when, but from a holistic point of view. How does dry eye affect the psychological, the economic impact of dry eye? And we did a little review article, and it got published in a journal. So emboldened by the fact that if a journal could accept it, perhaps Opal Hall could also accept it. This is why I'm here today. So we know the prevalence of dry eye is huge and getting worse. In COVID times, it became worse in children and adolescents, and kids who are on with digital eye strain because of e-schooling. Almost everybody got some amount of dry eye. All our computer programmers get some amount of dry eye. Tejas, you're taking my picture or the audience? I don't know whether to pose or not to pose. So challenges with photography, challenges with dry eye diagnosis. Definition of dry eye is still debatable. We had huge numbers of expensive workshops called the DEWS Workshop 1. Came out with one definition, and then the DEWS Workshop 2 in 2017 came out with another definition. They're gathering funds to have a DEWS 3 so that they'll have one more. There is also an Asian Corneal Society which has a different definition. So there is not only definitions, the absence of gold standards for diagnosis. It's not you take intraocular pressure in the patient's glaucoma because he's 40 pressure. So we don't have a gold standard. We have poor standardization amongst the diagnostic tests which are there, whether to use Shermer's 1, Shermer's 2, whether above 15, below 10, what should be done. Then we found out that corneal nerves have some role to play, and that causes more symptoms than signs sometimes. And sometimes you find if you are a careful examiner, then you get more signs than the patient has symptoms. And some of the what you might call gold standard tests are extremely expensive. You can't do osmolarity tests unless you're in an institution setting. So you have huge problems with this. But the impact of dry eye is comparable. So if you look at this slide, moderate dry eye. Now imagine that 100 is the highest you can have, and 0 is no impact on quality of life. So a mild dry eye, moderate dry eye is almost equivalent to, if you see severe angina or a hip fracture, they're almost at par. So mild and moderate dry eye is almost at par with somebody who's got a hip fracture or an angina or a heart attack. So it's that much of an impact. We always feel that dry eye patients are a nuisance to us, and we wish they would go away, and we give them 2-3 bottles from our second drawer on the left, because that is where you keep your dry eye medicines. But the patient goes away, but the impact on his life is such that he will visit 5 or 6 different doctors until somebody finally puts a hand on his shoulder. So patients with dry eye were 2 or 3 times more likely to report difficulties in daily living activities than those without dry eye. And this is normal activities that everyone will do. It's not some abnormal thing that is doing driving at express speeds on express highways. So there is a humanistic burden. Daily activities are impacted. The quality of sleep goes down. Again, something not commonly understood. Last 2 or 3 years, I've been asking every dry eye patient, especially females between the age of 40 and 60, whether they sleep well at night. And it's amazing that almost 80% of my patients say, no, they don't sleep well at night. And it's a vicious cycle because of dry eye, they don't sleep well. When they don't sleep well, the dry eye gets aggravated. And they don't want to participate in activities which are there because they're they're so troubled by their dry eye. So even leisure activities, recreational activities, they become introverts, they become withdrawn, they become depressed, all because of dry eye. Something which we don't look at the overall picture. So again, sleep disorders are very, very common. So check with them. Sleep deprivation, poor quality of sleep, sleeping during the day, sleeping at work or in school. Even kids sleeping in school, the teacher sends a remark back, the parents slap the child. But the issue is the dry eye. And look at the percentages. 40 to 45%, more than that in my series, but mine is a non-randomized, non-controlled, very biased study. So depressive symptoms I was telling you about, very, very real. If you ask them whether they get anxiety, it starts with anxiety symptoms and then goes on into full-blown depression with these. So as I said, ask these questions and you will know how badly the dry eye is impacting them. So all they need, along with the drops, is some amount of empathy to be shown. And why must we treat? Forget the patient itself, but it's a huge economic burden on the country as a whole. We don't have data from India, so I looked at some data from abroad, and they could quantify. Everything is quantified in the millions, billions, and trillions of dollars, and it's a huge economic burden to the person employing a dry eye patient, as well as to the patient himself, because he misses so much of work time. So economic burden, loss of work productivity, mild 91 days, moderate 94 days, severe almost half the calendar is lost because of this. Therefore higher economic costs, and somehow they came out with this 3.84 billion. Even if you don't believe this, it's on the lower side according to me. It will be more, even in our country it will be there. So dry eye patients, significantly, whether they're working from home or they're working from the office, it really makes no difference because the computer is common to both the places. So the productivity goes down. Even at home, they're not working as efficiently as they should. Absenteeism increases. So in conclusion, during the COVID pandemic, studies on quarantine dry eye were reported across the world. Prevalence of dry eye is likely to increase now because the digital devices have become more common. Digital schooling, almost every school or every school that could afford it would tell the patient, tell the kids, don't come to school, but we'll give you work on the screen. And most didn't have laptops, so they all worked on small little mobiles. We know that the smaller the device, the worse it is for dry eye. India is an emerging economy with a growing middle class, increasing urbanization, increasing use of the internet. We are growing much faster than any other country as far as internet connectivity is concerned. So this does call for an urgent relook at dry eye, and not only from the eye drop point of view, but again, as I say, we do need more Indian studies on dry eye. We have a paucity of Indian data, and therefore we are not sure. We are using Western questionnaires like the DEQ5 and the OSDI. We are not sure whether we should be simplifying it and using some simpler questionnaires which will bring out the impact of dry eye on the Indian environment. So it's a call to action for all of us that we need to understand a full medical history. Besides asking about medications, which we do, maybe we should ask them also about sleep patterns, about eating patterns, about anxiety, about depression, perform objective tests, ask probing questions, better questionnaires we need, and more effective management to treat the patient as a whole rather than just the dry eye, and do consider some alternative and supplementary treatments as per the DUE's classification. Thank you so much for your attention, and apologies for impinging on you. Thank you.
Thank you, sir, for very comprehensive update on dry eye and quality of life. So now we have another illustrious speaker in our instruction course, and he's none other. He's our own Dr. Suhas Haldipurkar, sir. He's from Mumbai, the past president of Maharashtra Ophthalmic Society, a pioneer of phaco emulsification in India, and I think one of the most diligent surgeons we have seen across the country, and a teacher par excellence. So it's a proud moment for us that he has spared time to give us insight that how our techniques sometimes go wrong and we land up in an unhappy patient. So we'll be keen to listen to Dr. Suhas.
Thank you, Mohit. Thank you, Quresh, for a nice talk. Uh, Thank you, Doctor, uh, for this invitation. And thank you, Michael. It's just that, I'm in another hall, so I may have to rush, although I would have liked to wait on to listen to your talks, which I normally like to do. The title that's given to me is "My Technique Went Wrong." Some of the clippings I show here, they may be mine, they may be my colleagues, but for the discussion, I have them here. Now, see, it is said that when you do a hydrodissection, uh, you don't be forceful, you have to be very gentle, especially if you have a case which is posterior polar or where there's a pre-existing, you are definitely asked to. Now, this is a case, it looks just a normal cataract and normal rhexis, and even the hydro is normal. But you see that snap sign? Now that's that typical pupillary snap. Now, if you have not picked it, then you have lost it. Sometimes, even after picking that, you think I'll kind of realign my Phaco parameters and will continue with it and I'll be able to do it. That's not right, because you do not know how big a tear that you have caused on the posterior capsule. Here, all the necessary steps are taken, but what exactly should be done is not done. Ideally, in such a case, what you do is you stop there, then inject viscoelastic under the rhexis margin so that the viscoelastic reaches behind, and then try and lift the nucleus out of the back and put it on the rhexis margin and carry on with the case. But that was not done. So naturally, whatever had to happen, it has happened. Then the next best thing you will do is, if that nucleus is not very hard and which can be easily managed by VR backup with fragmentome or with cutter, your job as an anterior segment surgeon is to complete the job as neatly as you can, and then do anterior vitrectomy. Let there be no vitreous in the anterior segment. You can see the tear is from one end to another end. Now these are the cases where you will not put a single piece. Obviously it's a 3-piece. The 3-piece lens, when you inject, see, very often for a young surgeon, if he has never used a foldable 3-piece, it requires little practice. First thing, if you are using a 2.2 or 2.4, you have to enlarge it to 2.8 or 2.9 because you want the cartridge to go in. You don't want to struggle there on an open PC. And once the lens, the leading haptic is on the iris or surely in the sulcus, you inject further. After you have injected, after you get the lens in the center, if the rhexis is small, then you can do an optic capture. But always remember to constrict the pupil using carbachol or pilocarpine, because you would want those haptics not to get entangled into the peripheral posterior iris tissue. Now this is a case, again an iatrogenic mistake. Now this is where the iris is completely plastered on the anterior capsular surface. It's a matte cat. The ideal thing, looking back now, would have been, even before doing any manipulation, I should have gone with the viscoelastic and done a visco separation. Normally in an eye where there is no uveitis and there is no plastering, if you have a myotic or a small pupil, you go with the spatula very confidently and try and just separate, because it is just stuck there without any firm adhesions. But here is a case where it's a long-standing plastered iris. That means the capsule is so firmly adherent that what I have caused in the process of opening up the pupil is I have literally, lacerated or ruptured the anterior capsule at multiple places. So obviously what you need to do is go with the cutter, and all the loose stacks have to be cut, because if while doing phaco, if those loose stacks get entangled, you cause further damage. Here you're worried that all these tears can extend into the periphery and really cause a problem. You notice me cutting it because if the iris is floppy and if the iris has a tendency to come into your wound repeatedly, there's no point in pushing it back. The safest thing is get that small bit of it outside and cut it, and after you do that, it doesn't come and bother you anymore. Then the surgery goes as normal. Luckily the nucleus is not very hard. Here you have to be careful with the cortical aspiration because there is no capsular bag from where you can get it. Every time you want to go under to get the cortex, with the second instrument you have to kind of open up the pupil, and again in an open bag you will not put a single piece, because single piece haptics are thick, and thick haptics can definitely cause inflammation, and this is a case of chronic uveitis where the patient already has a tendency to go on for, so you'll use a 3-piece length. This is a very old case of mine. I have simply kept it and like to show, because there's a tendency when you're working, when you're operating, your focus is at one point. It is and something else, or a lot of things are happening around where our attentions do not go. And when you look at your case post-op, then you realize, why the hell I did not realize it? Why the hell I did not see it? Now, I'm just rushing through. It's a normal case. You just make your, all right. So you have done your excess and you think everything seems to be in a proper condition, and you start operating. Your phaco tip has a sharp edge. Now, if you have a tendency to every time take your phaco tip to one side, see right now it's touching the anterior capsular rim. So 1 or 2 times you touch it, what it causes is a small tear there. See, the capsule will tolerate it once, twice, it won't tolerate it too often. But then all along my attention is focused on the nucleus. I'm not bothered about what is happening. Can you see that? So this I could have easily avoided if one, my technique was right. Number 2, after I notice that nick, what I should ideally do is take my second instrument out, go with the viscoelastic, take my first phaco tip out, and then do exactly what you do otherwise, in such a situation when you have a tear. What you do is fill the AC, deepen the chamber, go with the forceps, and convert the tear into a round opening. So that rhexis will have another small notch there. As long as the rhexis is in continuity, it doesn't really matter. Now this is again my very old case. You can see that signia, it's an old one, but I've kept it because see, you see that again there's a kind of a snap there. These are the things one has to watch and read from there. But what happens is, like today, after with experience, even if one thing I'll be more observant, or any of us with experience will become observant, and what I would do today is I wouldn't even handle that piece, because I know that however careful you are, your rest of the nucleus is going to dip in, and once it dips in, it's a long process. See here, what you do is you go from behind, do the levitation, inject some viscoelastic, and try and lift that nucleus into the anterior chamber, and once you have it, push some more viscoelastic, and then you have a choice to do today you would do lens scaffolding and continue with phaco. But in those days when lens scaffolding wasn't the thing, the only way you could salvage it was to go for a conversion. Now, this is a case of Phaco wound burns, which is a reality. Now, what causes Phaco wound burns? One, it's the continuous use of energy, not using pulsed energy, not using cold Phaco, and sometimes after you're injected visco, can I have one or two? Yeah. Uh, and not using, not being careful, because when you start, there's a lot of viscoelastic in the eye. First, ideally, you would aspirate it, and if you don't do that, that viscous plug gets into your phaco tip and it blocks fluid from coming in, and then you get this. Once you get this, now again your attention is on the nucleus and you're not realizing that you're causing a wound burn. And what happens is, with such burns, it's a disaster. The wound will never seal. So if you want to suture it, you cannot do a radial suture, you have to do a horizontal suture. And horizontal suture you must, because without that the chamber is never going to form. And to do that, after the suture is passed, if you suture on a shallow AC, once the AC forms, the suture becomes tight. So before you tie it, you inject air and try and deepen the AC. Once you deepen the AC, and this suture has to be taken little loose, and then again form it. And once that opposition of upper and lower surfaces occur, the the wound closes, and that's the end of the case. But what happens is, you see today, when the it's a in high cost cataract surgery, when you promise him roses and then you land up with this, it's difficult to explain. This is an iatrogenic zonular stripping, simply because some of the principles were not followed. Now you see that, you look at the beginning, it is a case where probably SICS was done. While doing SICS, a huge zonular rupture is noticed. So the suture is, the wound is closed, and another surgeon has taken over. So far so good. Luckily, except for the zonules in the upper part, half a minute, in the upper part, rest of it are okay. So the plan of that surgeon is to put an endocapsular ring, and then maybe if possible just put a lens, and that's it. But what you have to remember is, before you put endocapsular ring in such cases, you have to stabilize the bag with the hook, and it was not done. So what happens, in the process of putting an implant, you zip, you strip the remaining zonules, and then what happens is, you have unnecessarily caused further damage, and whatever chances you had are also lost. And finally, just when everything is done, now this is a patient where previous eye trifocal 6/6 N6, 2 days later he comes to the second eye. No, this is not that. That's a wrong case. Here no, this is another case. So what happens is, there's a I don't know what case is this. I guess this is a case where the haptic has broken. Yeah. So sometimes when you load the lens, it's not well focused under the microscope if you are loading it. If the staff is loading it, because of poor visibility, sometimes a haptic, if it stays in that flap of the cartridge, wings of the cartridge, it's easy for it to break. Once it breaks, you have a tendency, if the break is only small, you feel, okay, let's put the lens in and let's see. But what happens is, it's always going to decenter. So promptly you have to remove it. And cutting a lens is also a little tricky, because you do not want the lens, while cutting, to cause any damage to the endothelium. So first thing, you should have a forceps which can hold the lens, and once you hold it, use the second instrument to position it well. I have tried several lens cutting scissors, but the one that has worked best for me is a simple vanas, a long vanas with serrated edges. And here I'm doing it through around 2.9. As long as you're holding the lens tight, cutting it with this vanas scissors is relatively easy. All the time keep your viscoelastic and use a forceps to, tooth forceps, and try and pull it out. And then the second portion is also taken out and the lens is exchanged. So take home message is, each mistake that occurs during surgery, it carries a teaching point which, if picked correctly, makes us a better surgeon. Thank you so much. And sorry for taking little longer time, Mohit. I'm sorry. Thank you so much, sir. I'm sorry I cannot stay for longer.
Thank you, Suhas sir. Actually, these were the lessons for lifetime, and we all shall go with some lesson learned. And those videos were really very nicely made, and the message what they gave really would be a great insight, and we shall all improve upon our surgical skills till we meet the next time. Thank you, sir. Thanks for your presence. Now, going along to the course, sometimes what happens is that the error is there in the OPD itself. We are busy surgeons, we have big OPDs, long queues, and the error has already happened before the patient had entered the OT. So we actually missed in our OPD. These are some of the insights that I'm going to share, what mistakes I did in last couple of years, and would share a few of my cases here. It was a straight cut case of a female who came for surgery in the left eye with an immature cataract. The slit lamp examination showed a grade 2 cataract, fundus was normal, and IOL power was 24.5. Straight cut patient had a great multifocal done elsewhere in the other eye and wanted a similar multifocal here also. All was set and the surgery was done. Great centration, good surgery done. I was happy. 1 week, nothing was seen. After a week, patient comes, 618 vision, not improving. What went wrong? It was a quiet eye, no inflammation, nothing. Mood was upset, and literally I pulled my hairs when I realized that I had no record of the other eye. Nothing I knew. The patient was happy. I was happy she came for the other eye to me, and I just did it. So was she amblyopic? Might have been. The power used was 24.5. No, even she had no records today, but she was sitting right here because this eye did not improve. That surgeon was good and I was bad surgeon. Hence proved. So the lesson learned was, anyhow try to gain insight on what power of lens was used, what biometry was there, what refraction was there pre-operatively, see the glasses, do anything, but try to know the status of other eye before you operate the second eye, if you have not done especially. Now in winters in north we are worshipped, we are busy, people are in queue. The case scenario was, everything was set by an optometrist. Patient was presented before me on slit lamp, face down on slit lamp, well set, fully dilated pupil. All readings were normal, and yes, I decided to have a premium IOL, reasonably good, a bit large size rexis, good surgery done. Post-operatively again 618. I don't know why 618 is after my life. And now literally my mouth was wide open when I saw this lady. She had a deviated eye, and even her husband denied that the eye is deviated. And this picture was taken for the husband to show, see, she has a squint. This was never seen either by patient, nor the husband, nor anybody, nor myself pre-operatively. So one has to undergo cataract surgery to find out squint. Dr. Siddharth. So anyways, See the patient on torchlight before you take up the patient for cataract surgery. Many findings can be gained there. Now, these kind of patients, especially after COVID, great surgery, great vision, 6/6, but unhappy. Why? Sitting in OPD every third day, talking to all other patients also that I have so many problems. My eyes are watery. I keep rubbing my eyes. I have been given so many drops, 2 hourly drops. She had a hard cataract. Some keratitis was there. I also pumped prednisolone. That aggravated the dry eye again, and she has been uncomfortable and uncomfortable. See the staining, see the meibomian glands. I never managed it beforehand, but ideally, if you have a dry eye, meibomian gland dysfunction, never be in a hurry to have the patient getting operated. Try to treat it first, maybe a week or two, keep postponing for some reasons, and then take up the patient for surgery. Mature cataract can give surprises. A Morganian cataract, IOP was 20, mature cataract, other eye also had cataract, 660 vision. Patient wanted this eye first. I made sure there is no subluxation, there is no pseudo exfoliation. I had the B scan also done. I was wiser. Okay, fine. But then it was dilemmatic whether should I do a SICS and get rid of it, or should I do a Phaco. Patient paid me more. I committed myself for Phaco. I did Phaco. Now, as the pupil came down, I saw this monster. From where this came, she had a YAG PI. I never saw that. And then post-op vision was bound to be finger counting 2 meters. I knew it then and there what's going to happen the next month. And then this was the disc as expected. So she was on 20 pressure. She never disclosed that she has been putting these drops. She had a mature cataract. I had a normal B scan. I did a good Phaco, and see how bad a surgeon I am. So I'm labeled not to give good vision. A Pandora box came. See this child. He has something brown. You can see with that cataract on cornea. He sustained some trauma with a wooden stick or something. Very uncooperative, crying, running here and there. So wooden stick injury was in the history. She was very uncooperative. A total cataract was there. I did an indirect, could get a good glow, but the disc was just barely visible. I was sure that there is no RD or a vitreous hemorrhage out there. No point sedating him, getting a B scan done, and quickly he was just booked for surgery. And it was an easy Phaco to be done, a lens aspiration, and that was attempted. Now, peroperatively, this is a picture peroperatively. There was a hole in iris. Was it an entry wound? Something there? I don't know. All this was going in the back of my mind. I was operating, and then another hole, a PC tear. Was it a pre-existing one, or I did it then and there? I don't know. But there was a rent. Yes, there was a rent. There was a hole in the iris. Something brown was there in the cornea. But now it was all no point discussing. You have to complete the surgery. So, no, I will put the IOL in the bag. I kept it in the bag with this rent. And then, yes, it was done nicely. Patient vision was 660. Attendants were again howling and shouting and blaming and everything, what all they knew. And see this. There is a foreign body just near the macula. And my retina colleague also pulled my collar. Why did you place this IOL? Now from where will I get it out? But at that time I committed IOL. So I have put it. So these are the mistakes which we do. And yes, should have investigated more, but then this is done. And this Pandora box, I don't know what happened. They never came to me thereafter. Now, I had a retired scientist. IIPR Institute is there in Kanpur. A retired scientist came for me for surgery. 636 vision, a good juicy cataract. I was very happy, smiling and grinning like this. But then post-operatively 612 only. Not improving. Again, same scenario. I literally missed a small patchy kind of ERM and a pseudomacular. This is the OCT picture. This I missed in presence of a PSC. What crime I have done? But I missed it. He did not improve beyond 612. And you know, I got a letter from the advocate demanding 19 lakh rupees compensation. People are literally ruthless. We are sympathetic. Sample drop bhi le lo, ye bhi le lo, wo bhi le lo, but nobody spares us. So Now the big question is, should we do an OCT for everybody getting cataract surgery done? Now people will say yes, but at least scientific answer is a careful retina examination is must, the maximum care which you can give. You can use your tools, you can use your eyes, you can have a microscope in your eye, anything. So it's good to learn from your mistakes, but it's better to learn from other people's mistakes. So that's the dictum today. Thank you. And for the next talk, I invite my senior, Dr. Manish Mahindra from Kanpur. He's a brilliant surgeon and internationally acclaimed speaker, and he's director of Khairabad Eye Hospital. And he would be giving insights on how a wrong choice of IOL can lead to an unhappy patient post-operatively, despite doing a very good surgery. So over to you, Manish, sir.
In the meantime, we can take any question or any comment from the house if it is there. Dr. Tejas sir, would you like to make some comment?
Mohit showed so many mistakes and I forgot my mistakes.
Dr. Grover sir, I think Dr. Grover sir, you should come here and say some.
Lot of lessons to be learned from our day-to-day practice. Every day we make all these mistakes. It's just that we don't publicize them as much. Better to publicize it only rather than on their feet. I should learn from others' mistakes.
Dr. Dharmendra sir.
Without the mistakes, no one can be able to. So, in a story, we have to do some mistakes.
Yeah.
Until unless we don't learn, we have to watch our friends, what they are doing exactly. So, mistakes improve you and keep improvising and try to do less mistakes. You will be calm and quiet in the night.
In
So-
fact, Dr. Haldiporkar left, otherwise there were a lot of comments
Yeah.
from his guests.
Right.
One of them was the last one where he was trying to suture with the air in the chamber. I would rather fill it up with viscoelastic than suture and do a biomedical elevation and pressure remove.
Yeah.
It gives you the best.
That is also a very nice idea. Yes, Dr. Manish.
Good afternoon, everyone, and a very nice talk by Mohit. I think we all face such kind of patients in our practice, and it's really difficult to deal with these patients. So a good presentation, Mohit. I would be speaking on wrong choice of intraocular lens. In our practice, when we do cataract surgery, we do it routinely, and then in the end we put the intraocular lens, and we do it in a reflex, not paying attention to the fact that we may be implanting a wrong choice of IOL and then ending up with unhappy patients. So I'm going to show some of my cases where I implanted a wrong choice of IOL, and we'll discuss what all should have been done to correct those errors. So this was a case of a 35-year-old patient. He had retinitis pigmentosa with the nuclear sclerosis of grade 2 plus with the posterior subcapsular cataract. So we did an uneventful phacoemulsification and implanted a hydrophilic intraocular lens. Now this patient comes to me after 4 years, and this is what I see, an IOL bag complex sitting in the anterior chamber. So what went wrong here? So we were actually dealing with a case of retinitis pigmentosa, and as we all know, these patients have weak zonules, they have progressive zonulopathy, and therefore which leads to capsular phimosis because of unopposed capsular fibrosis, which can later on cause a subluxation or a dislocation, which can be either anterior or posterior. So this is what happened actually. So this is the whole IOL bag complex sitting in the anterior chamber. So we had to post this patient, and then I extended the wound. I pulled it out. Through that wound, you can see how the bag is, entangled with the intraocular lens here. So now I will gently peel this bag from the entangled IOL, and you can see the extensive amount of phimosis there, the shrunken bag here. This was followed by an anterior vitrectomy, And then I implanted an ACIOL. This is an old video. It actually should have done a scleral fixation or a glued IOL, or you can do a posterior iris claw lens here. So what went wrong here? Wrong choice of intraocular lens. I implanted a hydrophilic lenses, and although these lenses they're pretty easy to implant, they are single piece acrylic lens. They avoid additional flares on the zonules, but they don't resist the capsular contraction very well. And therefore, in this particular case, a 3-piece intraocular lens would have been a better choice. They are more rigid. They resist the capsular contraction, and therefore they prevent capsular phimosis. So the right choice to go would have been a 3-piece lens. Now, this was another case of a 36-year-old male who had a posterior subcapsular cataract with a compound myopic astigmatism with high K values. We did a biometry and then implanted a toric intraocular lens. And what went wrong here? We were dealing with a case of a keratoconus eye, and as we all know, to calculate IOL power and do a proper IOL selection is a challenge because of the fact that they have high amounts of irregular astigmatism. So putting a toric IOL is good for regular astigmatic patients for mild to moderate cases of keratoconic eyes. But if you're dealing with advanced cases of keratoconus, these lenses don't hold good. And we all know that the visual axis is not at the apex of the cornea, but on the slope of the cornea, and therefore you get artificially high K readings, and that's where you go wrong with your IOL calculation. And so you have to look at these things, to implant the right choice of lens. So how do we know that we are dealing with these irregular corneas? So simply, if you do a biometry, in these cases, you need to just look at the standard deviation and look at the values of the standard deviation. If they are more than 0.20, which is expressed as 0.03 millimeters, that means we are dealing with an irregular cornea here, irregular astigmatism, and then you need to further evaluate these cases, do a corneal topography, do a pentacam, and then evaluate them thoroughly. Another case where the IOL choice went wrong was this case, which was a 76-year-old male. He had a mature senile cataract, a myotic pupil, and he wanted a trifocal lens implantation, and we said, okay, fine, we'll go ahead with it. We did an uneventful phacoemulsification, implanted the lens right in the back, thinking everything had gone right. And this patient comes to me after a week's period complaining of poor near vision. So what went wrong here? Now, if you look at these trifocal lenses, you have a central refractive zone here, and which is surrounded by these diffractive zones for the intermediate and near vision. Now, in this particular case, the patient had a myotic pupil, so all these rings, all the diffractive zone was covered by the iris, and therefore only the central small zone was left, which was for the refractive zone was left for the distance vision, and therefore his distance vision was good, but the near vision was compromised. So in this particular case, we should have implanted a monofocal lens and told him that, this lens is good for you, and for near you would be requiring glasses, so that we would not have given him those, high expectation. Another case, this was a 52-year-old male who had undergone a LASIK laser 18 years back, had a nuclear sclerosis of grade 3+. So we did a normal, biometry, found out the intraocular lens power, implanted the lens. And the patient comes to me, a very unhappy patient. He had a postoperative refractive surprise, had a postoperative hyperopia. And although the unaided vision was 660, the unaided vision was 660, which improved to 6.6, but with a refraction of +3. And so he was very, very unhappy. So when you do, excimer laser, the anterior corneal surface changes, but the posterior corneal surface remains unaltered. And therefore, there is a change in the anterior and the posterior power, which alters the keratometric index, and that depends on the amount of the laser that has you apply. So when you treat these myopic patients, the keratometry readings they usually overestimate the cornea power, and therefore the IOL power is underestimated, thereby giving rise to postoperative hyperopia. So you need to evaluate these patients thoroughly. You need to retrieve all the preoperative data that you can lay hands on. You need to do a proper corneal topography or corneal mapping, use ray tracing if it's available to know the corneal sphericity, the posterior corneal astigmatism, the aberrations, and always under promise these patients, because when you under promise, then only you can over deliver. So this is the ASCRS chart that you can get on. You can use the Barrett calculator for post-refractive surgeries. And here you have to put in all the data, the pre-LASIK, PRK, whatever you have done, that has been done, the refraction, the keratometry, the post-LASIK refraction, topography, the CCT, the lens thickness, everything, whatever data you have, you just put in there, and then and when you submit it, you get an estimated IUL power, which is fairly accurate, and then you won't go wrong. So this is important here. Another case where we did we did a phaco emulsification, PCR occurred, did a proper anterior vitrectomy, and what we did, we just went in and put in a simple single piece acrylic lens in the sulcus. And patient comes to me after a month's period with an IOL decentration, had a sunset sign. The patient, now basically we all know that when we put these lenses, they rub against the posterior pigment epithelium of the iris, thereby causing dispersion of the iris pigments, secondary uveitis, secondary glaucoma, all these complications can occur. So the best choice would have been to put a 3-piece intraocular lens. They have they are larger lenses, they sit in very well in the sulcus, and the haptics are thin, they are angulated in such a manner that the optics don't rub against the posterior pigment epithelium, and the postoperative inflammation is very minimal. Now, this was another important case where it was a 48-year-old myopic patient, had a nuclear sclerosis of grade 2. We did a refraction, he had a -2 diopters of refraction before cataract, and we implanted a monofocal intraocular lens here. And the patient was absolutely miserable after the surgery. There was a complete loss of accommodation, and despite an unaided vision of 6.6 for distance and a near vision of N6 with plus 2.5, the patient, had a lot of complaints. And when we told him that, your distance vision, has got corrected, it's only for near the vision that you'll need glasses. That's, because you have a monofocal lens there. He said that all my life I've never used glasses for near. I've always used glasses for distance, and for near I've been comfortable without spectacles. And now you have done the reverse for me. So this is absolutely wrong. It's a miserable surgery. So it's important here to discuss, we need to discuss such patients and counsel them and treat them in specifically, what they need, what is the best vision they would require. And you need to overcorrect, so you can slightly overcorrect the IOL power to make them slightly myopic, so that they are, whenever they are using glasses for distance vision, they're comfortable because they've been using it for so many years. But for reading, they want spectacle, they are spectacle independent, so they want to be without glasses. So that's where you need to every patient needs to be counseled, and you need to talk to them. Presbyopic correcting glasses are good, and you need to explain the pros and cons of the surgery to the patient. Now, whenever you're implanting a multifocal or a trifocal IOL, it's important to pay attention to the angle kappa. Often we don't do it, we just go ahead and you're thinking that, okay, he has he doesn't have a astigmatism of more than one diopter, and the patient is really reasonably fit for a trifocal lens. But angle kappa is very important. What is angle kappa actually? It's the distance between the center of the pupil and the visual axis. Now, if you look at this diagram, you'll know it better. You see here, there are 3 dots here. Now, you have the green dot, the blue dot, and the yellow dot. If you look at the green dot is the optical center, which is the center from the temporal and the nasal limbus. The blue dot is the center of the pupil, and the yellow dot is the center of the visual axis, that is the line drawn from the fixation point to the fovea. And your lens should be in this angle kappa, which is between the pupil center and the visual axis. Now, if you look at diagrammatically, you will see here this yellow line passing from the fixation light to the visual to the fovea. This is the visual axis. The green line, which is passing through the optical center, that is the center of the nasal and the temporal limbus, is the optical axis, and the blue line is the pupillary axis passing through the center of the pupil. Now, you have to pay attention to this angle kappa, which is the angle between the pupillary axis and the visual axis. So this is, as you can see here, now here the trifocal lens is well centered, and also look at the anterior and the posterior Purkinje image, which should fuse, and this should lie in the center of the pupil. So whenever you finish your case, ask the patient to see at the light, see at the microscope light, and see whether your central part of the trifocal lens
is right in the middle, and all those Purkinje images are coinciding with each other and lying in the center. So how do we know that the particular case is fit for a trifocal or not? How do we know this angle kappa? So when you do your IR master and you see you see the white to white values, you will notice the px and the py value. Now when you add up these px and py values, it should be less than 0.6 millimeter. If it's less than 0.6 millimeter, that means that this patient is suitable for trifocal and you can go for it. If it's more than that, that means your angle kappa is more and these patients are not fit for it. So to conclude, a thorough pre-surgical evaluation is a must in all our cases. With careful and surgical planning and skillful and diligent surgical technique, you will always get good results. But most important is choosing the right or choosing the proper IUL, and you should have your inventory well maintained so that in case of any complication in any mishap occurs, you can choose the right lens, and you will end up with happy patients. Thank you.
Thank you, Manish sir. These are the things less discussed but very important, and we somehow are governed by the commercial reasons what kind of lens we are going to implant. But these are subtle things that can have large impact on the long-term outcomes at least. So these are very good takeaway points. And Dr. Tejas was discussing with me. He wants to make some comments. So please, sir.
So I think 2 points. One is IUL. We never mentioned IUL. Thank you. We never mention IUL ever. No staff also mentions IUL ever in their discussion or counseling with the patient. We always use the word monofocal technology or extended depth of technology and multifocal, or we say progressive these days because all these people have already worn a progressive glass. So what happens is when we do not speak about the IUL, yes, ultimately the conclusion is kaun sa lens daloge. So we always say that will be decided by the sonography, and only the sonography will decide. Now what happens, the patient comes and says, I want this particular lens. And these are very difficult. If you say, I'm not going to implant that particular lens, they go away. They go to the next doctor. So what we actually do is that, sir, we will do your sonography. And in the sonography, there will be a couple of choices of lenses. Of course, they will be fed by you only. So then you can very easily tackle this patient from VVT to say synergy or something like that. So we never mentioned IUL. Second very important message was, we never choose 0 or plus 0.25. We always choose minus 0.5 to minus 0.75 in the first eye. Then we have a look, we talk to the patient. Once a patient is very happy with minus 0.5, minus 0.75, we make minus 1 in the other eye. And these patients are very happy. In fact, there are hardly any patients in our clinic who are 0. And at minus 0.5 and with some pupillary dimensions helping them, they are always very, very, very happy. And with a minus 1 in the other eye, practically the same thing we practice with our eye hands technology also. There are 90% of them are spectacle free. The third thing which I actually wanted to mention about is this choice of IUL. IUL should not be actually ever discussed. Why are we discussing IUL? When it comes to IUL discussion, we say IUL is only 5% important subject in the entire visual axis, and we are removing only one part of the 1 million parts. We do not know what the other 99 lakh parts are doing, so we might not get actually a 6/6 vision because we are only removing one part of the system. We do not know how the system is going to interact with the other parts, and that actually is a plan B if you end up with a 6/12 vision or something like that. Thank you.
Thank you, Tejas sir. Now, for the next talk, I invite Professor Shalini Mohan from Kanpur. She heads the Department of Ophthalmology at GSVM Medical College, Kanpur. A very meticulous and a perfectionist surgeon, and she would be giving insights to us on how to do a perfect toric. So, actually, with the supply and demand increasing for these toric lenses, they have increased implantations now. So, when the toric goes wrong and what happens, this is the topic she is going to take up for us. Welcome, ma'am.
Thank you so much, Dr. Mohit, and thank you, AIOC. I'm delighted to be part of this wonderful course with wonderful talks happening. So we all are doing toric IOLs, and we know that, yeah. So we know that these are the best options for astigmatism correction. And there are a variety of IOLs which are available to us, and any company we can choose as per our own choice. Now I'll be discussing this case. It is moving automatically, I guess. So this is a 63-year-old male patient in whom we can see. So this is the IOL master reading, and we can see that there is significant amount of astigmatism. It is moving on automatically. Yeah. Thank you. So there was significant amount of astigmatism, and these data were fed in to see that which we can put the toric IOL. And this is the calculation sheet in which the incision was planned at 150 degrees and IOL was planned at 180 degrees. So what happened next? When first post-op day we see that there is certain amount of rotation, and we expect this the most common complication in our scenario. Now this is another similar kind of case where the IOL was to be implanted at 83 degrees, and this is almost 1 week post-op where we see there is certain amount of rotation resulting into residual refraction of 0.5 spherical and -1 cylinder at 90 degree. Now coming to case 3, I have put these 3 cases simultaneously because they are of similar kinds. Another toric IOL implantation with 19 diopters of lens at 40 degree, but 2 weeks post-operative, the vision is 618 and patient did not improve. When we did refraction, we found that vision with pinhole was 6/6, and this was the residual manifest refraction, which was 0.75 spherical and 1.5 diopter cylinder at 50 degrees. So what we do, we have to check the alignment of the lens. We need to dilate the pupil nicely, and this is the alignment. So whenever we check, the important thing is that is there any rotation? If there is rotation, how much is the rotation, and how much we need to re-rotate the lens so that it falls in perfect place. So to measure this can be a costlier machine, which is the eye trace, or you can do it on the slit lamp by thinning the slit beam. So you can make the slit beam thinner, and then you need to rotate the slit beam in the axis of the lens you have implanted, and then you can read the reading from the markings on the slit lamp. So this is one method which you can do. Now, I find this iToric app by Dr. Saurabh Patwardhan very, very useful. What we do in this particular app is we need to download this from Play Store. In your mobile, you can download it, and then you take the... Now, this is the iToric app. You click the picture, the photograph, and then just put this iToric app and rotate it, and then you pinch it nicely. Once you pinch it and adjust along the markings, and then you see where is the IOL placed. Now here you can see the IOL, and here you can put that how much degrees you wanted the IOL to be there, and now you see that once you put it 40 degree, the IOL markings are at 30 degree. Now, important thing about this is that once you rotate the mobile, the protector also rotates. So even if your mobile is tilted, still it will take the correct reading. So I found this to be very, very useful. And if you can do this, you will also find it to be very, very useful. So what we need to do? Obviously, we have to re-rotate this IOL. So there are certain websites available to assess the amount of astigmatism, amount of rotation which you have to do. It can be astigmaticfix.com, assort.com, or ASCRS website for calculation. So we fed in the data, and what we found that we have to rotate the IOL by 10 degrees. And so we went on for the IOL rotation. Now, whenever you are rotating the IOL, you can actually freshen the incision, and I found that if you can put your irrigation from the side port and do rotation under hydration, it is the best thing to do it, because once you put the viscoelastic and do the rotation, again the chances of re-rotation increases. So just put your irrigation from the side port, and here you can see now it is nicely coinciding with the markings. This was the Acrysof toric lens, and the other one is the Biotech. I don't have any financial interest. So hydro rotation of the lens is very, very good. Now you can see the lens is very well implanted, and now it corresponds to the 40 degree. Again, this is iToric marker. So what lessons we learn? Be meticulous at your wound construction. Wound should not leak. There should be a well-centered capsulotomy which overlaps the IOL nicely all around so that it doesn't rotate. Whenever you are positioning your IOL, the lens matter should not be there. It should be absolutely clean bag to implant the IOL. If you are doing it under viscoelastic, just make sure that it is slightly positioned short of the marking, and then you rotate it by your bimanual or under hydration. And then if you are doing it by OVD, try to check that all the OVDs have been removed from the behind the IOL also. So just go behind the IOL and remove all the viscoelastics, and then again reposition the IOL and again replace along the markings. So removing of this OVD is very, very important. Or you can do hydroimplantation in the, as you see in the lower video. So you can implant it just under hydro, and then I use this Osher dumbbell dialer, which is very, very safe to rotate the lens and position it nicely. And then hydration of wound is also very, very important. Neither make it too tight, neither make it too nor lead the eye too hypotenuse. Now coming to another scenario, case 4. Now this was again a toric IOL which was planned, and you can see this Alcon toric calculator. The lens was to be planned at 174 degrees. And yes, next post-op day, it was very nicely placed at 174 degree, but still there was residual astigmatism. So now what is the cause? Rotation bhi nahi hai, and then still this is the problem. So what we went again retrospectively analyzed our data, that what was the problem. Rest everything was fine. K was fine, location was fine, incision location was fine. But then suddenly somebody said, SIA check kiya tha. Then I realized that yes, definitely I had checked the SIA. But what I realized that it was pretty high, 0.55, and this I did at the beginning of my career when I started doing surgeries. And now after almost 20 years, definitely it is bound to change. And I redid SIA, and what I found that it is now reduced to such minimal amount of 0.16 and 0.23. So obviously, once you have improvised your surgical procedures, so it is bound to lose. So you need to recheck. Though again, when we calculated, it was not, the IOL per power coming was T5, and what we had put was T4. So obviously we need to change the IOL, but because it was only 0.75 of residual astigmatism and patient did not complain much, so we thought that okay, we will leave like that only. So lesson learned is we need to update ourselves and the data also. So surgical SIA calculation is very, very important, and I request everybody to do it for yourself and do it separately for your right eye and for your left eye, because it might come different. Now coming to another interesting case which was planned for Phaco with toric IOL implantation. Anterior segment was satisfactory, but what is this now? 3/60 vision, and it was improving to just to 5/60 by pinhole. We checked the posterior segment. We thought there might be some problem in posterior segment, but it was perfectly all right. So what was the issue? Refraction. It was coming to almost double, +4 and -9 diopter cylinder at 89 degrees. So initially it was 4.5 diopters of cylinder. So what wrong we have done? So we checked the rotation, this calculation data, and what we found that double the astigmatism will only happen if IOL is oriented exactly to 90 degrees. So again, we rechecked our data. So this was the IOL. There was no rotation at all. We expected that it should have been rotated by 90 degrees, but it did not. So again we checked our data, and what was the problem? Was it a manufacturing defect? We thought. But then we realized that when the data was fed in, the flat axis was fed in at steep meridian and vice versa. Therefore, everything went haywire, and when we fed in the data correctly, this is what we saw, that the IOL should have been oriented at 169 degree. So what we did, we just rotated it at 169, and now the patient was happy and vision was recovered. So the message is that verify it yourself. Don't rely on others. Even sometimes the company guys, they are new to it and they might the data feeding would be wrong. So better to verify it yourself. Now this is another patient which we did, but still the vision was just 612. There was no rotation. But what was the problem? Check for the other causes also. Now this was the scenario. Dry eyes already has been discussed by several of my co-speakers, and this was the problem. There was severe dry eye, and anterior meniscus height was reduced. So we did a topography for this patient, and you can see a significant amount of inferior steepening, and you can see the Myers. These Myers, they are all distorted on and not clearly taken. So this patient was treated up for dry, but better to treat it beforehand. And then after treatment, obviously the problem was solved. So rule out other causes. It might be a subepithelium basement membrane dystrophy. There might be pterygium. This is before pterygium removal, and after pterygium removal, the topography improves. Now coming to another case, again a walk-in patient for cataract surgery. He said, "Doctor, मुझे surgery करानी है." And as all optometrists, they started doing the workup. And after workup, now it is routine that autoref, K and IOL master both is being done regularly at my center. So in autoref, it was almost -3 diopters of cylinder, and when we see the IOL master, it was only to 1.54 diopters of cylinder. So I inquired my optometrist that why is this? So she said, because readings were not coming on IOL master, so madam, I have put a drop of lubricant and then did. So I said, better to go for topography. And look what is the picture. The Myers were not at all completely forming, and we were not getting anything. So, and clinical picture was like this. It was full of superficial punctate keratopathy, and there was a corneal opacity at the inferior location of the cornea also. So never plan toric IOLs in such a patient. Thankfully, we did a proper workup, and then we treated the situation, and then only we did the cataract surgery. So it was not primarily the cataract which was causing reduction in vision. It was basically the ocular surface problem which was leading to infection. Now, a few more lessons. Now you see this calculation sheet, and you see the IOL placement is at 160 degree, and for similar findings you can see that the IOL position is 171 degree. So this was a Zeiss lens, and you should use the same calculator for the lens you are going to put. For Zeiss lens it was coming to 161, and for other calculator it was coming at 171 degree. So make sure that you are using same calculator. Similarly, this is the instrument with which you mark your toric patients, and bubble marker. Now always check this also. Now this was the instrument used by one of my colleague, and he was doing surgeries at 2 centers. At one center things were perfectly all right. At other center there was always an error. So what was the problem? This was the bubble marker. And once you keep it along the horizontal line, see how it is oriented. And just to check the markings are actually not across the 180 degree, but the other one is slightly elevated. So sometimes these small mistakes might happen with the bubble marker also, and that might lead to problems in your results. So always check your instruments also. So the take-home message is that toric IOL, they are very, very rewarding. Patients are very happy, but we should be very careful with our measurements, our calculations, our markings, positioning, and instruments too. Thank you so much for your kind attention.
Thank you, ma'am, for highlighting very, very fine points out there. These are the things to be understood by those who regularly operate and do toric IOLs. And I think a very comprehensive outline of the errors possible. So we learned bad surgeons like me, we learned good surgeons, we learned from professors, from pioneers of Phaco emulsification, but one name is left to listen from legend. So now I call upon the legend out here. Grover sir is here to bless us. No introduction, not even a line needed.
I wouldn't have come unless I knew I was the only speaker left, so I had to come with this. I've learned a lot because I make all the mistakes that every speaker spoke about, but I make some additional ones, so I'm going to speak about these additional ones. So, communication is an art, a science, and a lot more. So we're going to talk about how communication difficulties can lead to difficulties other than all that we have spoken about. So let's begin by understanding what communication means and particularly what it means in the context of our communication with the patient with regard to cataract surgery. So either imparting or exchange of information by all means, speaking, non-verbal, and eye communication and all that. Why do we need communication, particularly in the context of when you are planning to operate a patient? It helps us better understand people, particularly important for us besides situations. It helps us with a lot of things, but most of all for us, for cataract surgeon, it builds trust amongst the two parties involved, the surgeon, the surgical team, and the patient. What we often neglect is the other components of communication. We all know about what verbal communication means, but it is the other language, what we communicate in terms of empathy with our eye contact, with a feeling of sharing what he's trying to communicate. That is, the non-verbal communication is very important. And the most important thing, as it is said here, is in communication is hearing what isn't said. So you have to understand the patient's psychology, his mind makeup, his thoughts, which he's not able to say in words. So as the previous slide said, empathetic listening is what is important. You need to be having a two-way communication, understanding what is going on in the patient's mind. The biggest communication problem is we listening normally in order to reply to that. Our mind is concentrated on what we're going to say in reply rather than on really understanding what the verbal and non-verbal communication is trying to say. Another important lesson is what Albert Einstein said. Communication should be simple, easy to understand. What we often say in jargons or in technical terms or superficially may not mean much to the patient. And you're able to do that once you understand a thing better. So that's why Einstein said, if you can't explain it simply, you don't understand it well enough. So putting things in simple words is a very complex thing. So let's come to the specifics of communication with a cataract patient. This communication needs to be preoperative, during the surgery, and postoperatively. And preoperatively, there are a lot of things which are communicating in your setup. Is the ambience, the displays, and then the communication that happens from your team down the line, right from the front desk to the optometrist, to what you communicate, to what the counselor communicates, and even afterwards when he goes through the optometrist, through the pharmacy and all that. So it is a whole set of communications which is important, and the impression that he carries or the knowledge that he takes back has a lot to do with the entire set of your environment and entire set of communication ability of each one of your people. So it is important to impart those lessons to everyone.
So one important aspect of communication is understanding the patient, and what we often forget is the attendant, because often the decision maker is the attendant. So you have to understand his background, relationship, and also understand that this is the decision maker. For the patient, you need to understand, of course, we all talk about occupation, professional requirements, visual requirements, but these are some things which are only discerned when you interact with a patient. Many times, some of these VIPs say that, okay, we'll come only on the day of surgery and get operated. मैंने biometry करा ली है, मैंने दिखा लिया, मैंने pupil dilate करा के fundus दिखा लिया है. But I'm very uncomfortable unless I've met the patient, because you don't really understand the patient. You don't really know how to interact with him unless you have had a session with him, a pre-operative one-to-one with him. So that, I think, is very important. So you have to pick up the over-anxious patients, hypersensitive patients, demanding patients, and make your decisions accordingly. Of course, this is purely technical. We all know that you need to communicate nature of disease, options in management, pre-operative preparation, informed consent, nature of surgery, experience during surgery, what he'll feel, what we expect him to do during surgery, post-operative difficulties that he'll face, expectations, precautions, and financials. I think this is very important. Now, of course, consent needs to be very specific and detailed, and this, in today's era, needs no emphasis to this audience. And this, of course, has also been repeated to you several times, that you always try and not raise expectations. And some of those expectations come from the public कि आपका तो वहाँ ऑपरेशन पे जाना है और 5 मिनट में हो जाता है. Some patients come and tell me कि ये तो 5 मिनट की सर्जरी. मैंने कहा आप भी कर सकते हो, आप ही कर लो. So those kind of expectations, that it's a very simple surgery. Simple surgery का word तो कई लोग use करते हैं कि इतनी simple surgery है. फिर particularly if they've had a tough experience कि सबका तो बिल्कुल अच्छा हो जाता है, इतनी simple surgery है और मेरे कोई दिक्कत हो रही है. Obviously, you are the one at fault. So intraoperative, putting the patient at ease is very important for getting a good result, because only then he'll cooperate well. Especially topical के era में, it has become particularly important that patient is at ease and you have communicated, explained what the experience will be like, dimmed the light in the beginning when you're working with topical, then gone on to, and that attendants or assistants are in the habit of explaining some things when they're sticking the plaster, or the drape, and so on and so forth. And so some appreciation, some expectation that you have of him, if you explain to him, it makes for a huge difference. So just one sentence, lots of patients have said this, that the one sentence you speak in the beginning before you start makes a lot of difference to our, and of course if it helps if old songs are playing in my OT, which they always do, because many patients are that age group where they appreciate the same songs that we do. So that is the difficulty for young surgeons. Okay, post-operatively, again, we need to be explaining a lot more, because that is where a lot of complaints come. If there is a system in your hospital of somebody calling up the patients on that day, it makes a huge difference. I try to implement it most of the time. Sometimes, of course, they forget, but and inquiring from them, and somebody being available for a call, because unless that is present, they will come up with a lot of complaints about that. So you need to explain the difficulties that they will have. Now let's see, where do we go wrong? There are a number of inadequacies. We'll talk about these 4. One is that if we don't build enough relationship or trust, it's normally a 5-minute interaction, but those 5 minutes are enough for building a kind of trust. Most important thing for building that trust is whether you heard what he wanted to say, because one of the commonest feelings left in a patient is that he could not tell what he had, even if it is immaterial. You can see everything on his eyes, but that's not enough. That's the one thing that you learn with experience over the years, is that many 20-25% of the illnesses are organic, and 75% of it is with all the overlay of all the other parts of personality and so on and so forth. So this is very important. Of course, communication again helps you to understand what the patient's requirements are. Inadequate information that you are providing to him, we'll talk about this a little more, and inadequate post-operative explanation and chair time. So which all may help to have a patient who has expectations that are unrealistic. So communications, so inadequate relationship or trust building happens if you have not spent time with the patient. This has been repeatedly stressed. And intraoperative communication, those are the two times when you are personally going to interact with him as well. So those are the times when you can build this relationship, the feeling that this is a person who cares for me, which is what is going to matter in what happens post-operatively. And this is the job of the whole team, whether they've assessed the patient's requirements well in terms of decision making on what procedure to do and what lens to put and how to deal with him post-operatively. And if you've not given adequate information, many a times things will all go well and you expect him to know a few things, you expect your setup to have conveyed a few things, but when anything goes wrong in the results, then this is what is going to matter, that this was not informed to me, that this particular complication was not explained to me, and so on and so forth. So then all these become very important, and financials often are very important in this. And then of course, especially when a complication happens or there is a reason for patient to be unhappy, then this becomes particularly important, which is to have that extra chair time post-operatively. Maybe give a little priority to the patient who has an endophthalmitis, see him early, spend a little extra time with him. So this part of communication in those cases becomes particularly important, where there has been something which has not given a perfect result surgically. So appropriate communication at all stages holds the key to patients who are grateful and who are going to be your permanent ambassadors, or they're going to be your litigants. So I think communication will hold the key in choosing the right results for you. Thank you.
Thank you, sir. With your wisdom and experience, you have said some golden words, and after doing everything, this is the conclusion, that if our communication goes wrong, sometimes we'll end up in problems. Patients say that we were not being treated well, either by the doctor or by the staff or counselor or whatnot. So from the start to the end, it's not just the medical science, it's our communication skill that decides our growth and our mental peace also in the current practice. To each one out here, I extend my heartfelt thanks for your benign presence, and we conclude this course. I hope this was worthy and each of us gained some insight, some take-home messages so as to improve upon our clinical practice. I thank all of you once again from the core of my heart. Thank you. Your lunch is there set all.